So oncology is one of our busiest customers for CT because we can localize a mass lesion, where it is, how big it is, whether it involves the bone or not. And that doesn't matter which body part they're looking for it, so that's good for them. If they want to have a surgical biopsy for some bigger mass, we can tell them post-contrast which one is necrotic and which one doesn't look necrotic, so that's useful. And then we'll talk about metastasis screening for a second. Examples of cardiac tumors. This is an hemangiosarcoma, which you would expect to have a more contrast enhancement, but it didn't. And this was bleeding into the pleural space and causing a pleural effusion. Here's a heart-based tumor. You can see the center isn't contrast enhanced, but we could get an aspirate from that. And there's no other way of getting an aspirate from this. So it's either this or no cytologic diagnosis. If it's a body wall, then CT is very commonly used to look for the extent of fibrosarcomas, often these vaccine-associated sarcomas. It's again, since it's not a microscopic tool, it's not 100% ideal, but it's the best macroscopic tool that you could have. And within the abdomen, you can see contrast enhancement. I think, oh, there's a mesothelioma. So it arises like from the internal peritoneum here, and there's a large cystic component to it. And it allows you to, this is not basically, on ultrasound, this looked more like a peritoneal effusion, but it's not an effusion, it's a cystic fluid-filled mass lesion. So all of that is important information. We also talked already about of pulmonary metastasis, and there's no question that it really supersedes radiology. So whenever you would plan to do it radiographically, then it would make sense to replace this with CT. Now this creates some very strange new problems that we have, and that is, in the workup of most oncology patients keep coming back. They have their rechecks every 2 months or something in that order. And it's, for economic reason at the moment, still not practical or possible to always re-CT them. So they will maybe have a CT to diagnose them initially, but then the follow-up would be on radiographs. And if you detect a small nodule on a CT, then you wouldn't see it on the radiograph. And therefore we already have our diagnosis we don't need a radiograph. But then when the dog comes back later, 2 months, and you do take radiographs and you don't see a nodule, then you don't know, has it grown at all, or how much bigger is it now? And so that's why sometimes we do radiographs of patients like this, although we don't actually need it, but you need it for the follow-up because you need to have something to compare it with the same methodology that you can see it with. Although I would argue if the nodule is really small, it's pointless because then likelihood is you will not see it. So you will have a clear thoracic radiograph, so there is nothing to measure there. It's more of it's already a little bit bigger and there's something to see. And you also have, what was it? I had this really strange discussion with our oncology colleagues about this because we have these two different modalities that we use, and Norway's not always doing both of these studies. And
it was something about prognosis.
Yes, it does have some. It has to do with prognosis.
That you were telling
Oh,
the owners.
I know. No, hang on. I know now. I remember it now. Okay. So we did a CT, and of tumor X, which I don't know what it was, and it had a small metastatic lesion, let's say 3 millimeter. And now they are assessing the prognosis for this patient with the metastatic lesions. But the literature that they have is based on radiology. radiography, not CT. So the oncologist comes back to me and says, well, I'm going to treat this as category of tumor X with no metastasis, because the papers that were published were done with radiographs, and a 3 millimeter nodule wouldn't have been seen under radiograph. But I said, yes, but it has a met, it's there. How can you ignore it? Yes, but as far as radiography is concerned, it wouldn't be there. And to me, there's something really wrong about doing it this way. But I can also understand why he wants this. But even if you take a radiograph and you still don't see, I still know there is a met there. So I wouldn't want to put this dog into a category of saying, there's no met. Basically, what it means is, at the time when the study was taken, there was no met seen on radiographs. It doesn't mean there's no met. But you see that there's a problem, that we find too many things and the oncologists don't know what to do with all that stuff. All trying to do our best to figure. So you saw that met already. Accessory lung lobe, Ditzels, we're gonna get through that. We have done that. Lymph node, we have done that. RECIST. This is a very popular thing in oncology. It's called Response Evaluation Criteria and Solid Tumor Criteria. And solid tumors, I think. The criteria at the end is wrong. So this was developed pretty early on for pulmonary nodules in oncology in human lung CT. And it's again to get a more objective answer to the question is this a progressive disease or is it stable? And because of the difficulty in measuring these things accurately between different time points, they said, like, no, we're doing a really simple thing. We're not going to do multiplanar reconstruction and find the biggest dimension of the tumor, nothing. You take the transverse CT images as they are, and on that, whatever the biggest distance you can get, that's your measurement. And the next time you repeat that, and you find again a nodule with the same nodule, hopefully, with the biggest measurement. And it doesn't have to be in the same orientation. Whatever is the biggest now. And you take that. And if that is whatever is, I'll come to, I think it's 20% or more, then that's a progressive disease. And if you have more, if you cannot measure it because it has diffuse margin, then you cannot use RECIST. And if you have multiple lesions, then you measure all of them and add them all up together into one measurement. And if you have lesions that are necrotic in the center, that are not contrast in the middle, then you can't measure those too, because a big lesion with a big center of necrosis doesn't necessarily represent progression of disease. So there are those exceptions. So a complete response is not there, and a more partial response, if the sum of these linear measurements is decreased more or equal to 30%, or progressive if it's more than 20% increase. And if you have lots of nodules and you now have one more and the other one's measurements are unequal, that's also progressive. So that's how these are the rules of RECIST. And this was never really designed for anything else than lung tumors before, but people just keep using that. Like, oh, well, why can't we do that in the abdomen or in the head or wherever? But they don't work always that well, and you still have the same problems with measurements. You know, it's a dangerous thing to be too religious about these measurements. Nobody should make, if you have a borderline case, you never should make a decision based on being a decimal point upper or lower, whatever your cutoff value is. Because this is macroscopic imaging, this is not the accuracy that we can deliver here. So for tumors in the brain, that was also only developed for MRI, they have in humans RANO, which is response assessment to neuro-oncology. And on that one, they said, well, this one measurement isn't good enough. We're going to do two, whatever the biggest dimension is, and then the orthogonal to that. And then you lump them up as well. And then they adapted that to veterinary tumors as well. And here the issue is that in most brain tumors, we don't really know what they are. So without the histology, this becomes a bit more important to get some sort of grip of what we're treating here. So they're trying to do, I just did this, this is not an MRI and it's not a brain tumor. I'll just do this as an example, the difference between RECIST and RAVNO, if you would do it. So in RECIST, you take the biggest measurements, and if you have another mass of that, you would add them up, and that's your SLD. In RAVNO, you measure the biggest distance, and you measure in a way that you don't include the necrotic centers. And then you take not a linear measurement, but an area measurement. And these areas are then also added. And that's your sum of products, because that's a product here. And you have similar criteria then in RECIST with RAVNO to assess this, whether it's stable, progressive, or partially responsive or responsive. So these are all new things that we work on together with our oncology clients to get more information. And also it kind of reflects the changing patient population that we get in general. In the old days, we had dog comes in, referral center, diagnosis done, horrible disease, surgery or euthanasia, possibly medical treatment, that's it. Dogs either cured, gone, done. But now it's like in humans, like they keep coming back. It's something we can do, but we're not going to eliminate it. And so we have dogs that have 10 or 12 repeat series. They get another CT, another MRI, particularly if they're insured, so you can do all these things. So you now have to compare all these things that we never had to do before. And so it all gets more complex, and then how do you compare those things? And those things are attempted to objectify a little bit more. But the downside is really that if people get too religious about these numbers, and like they only see the 20.2% instead of looking at the whole picture, and that is not going to work. This is all about RAVNO. The CT angiography is another thing that's helpful in oncology. For tumor assessment, because you see the vascular involvement, vascular anomalies, and hemorrhage and thrombosis. So this is a highly vascularized thyroid carcinoma. So when the surgeon sees that, they're not too happy. So this is a very difficult surgery to remove that. This is extremely hemorrhagic. So, but you know, you better know before you make that decision whether you go in there or not. This is a dog which has a retroperitoneal hemangiosarcoma. That's a kidney. It wraps around the adrenal, and you can see all the hemorrhage in the fascia and in the peritoneal and retroperitoneal space. This is all bleeding from there. Adrenal tumors with vascular invasion, again, surgical decisions are made based on this. Thrombosis and tumor invasion into the caudal vena cava. Here is a thrombosis in the cava cranial to the adrenal lesion. Okay. So now we talk a little bit more about intervention itself. So using CT and interventional procedures, the good thing about CT is it's cross-sectional, so you don't have the problem of superimposition. We can do more real-time now with helical because we're faster. The downside is you can't really stay in the, it's not, well, we do for some things, but it's problematic to stay in the room for operators, particularly if you have to have your hands close on it. So this is the problem. In people, in human radiology where they have CT fluoroscopy, some of the operators are pretty close and there are really incidences of radiation damage to surgeons and things like this. So it's not great. You get a lot when you're close to the actually beam with. So, and if you have metal, it does cause artifact at least. CT guided biopsies and FNAs are available for the head, for the brain. And it's not commonly performed. It's not quick. It is pretty difficult, the whole procedure, but it can be done. You can now buy those commercially, and they do have high, I think relatively high side effects, seizures, epistaxis, I think even death was among them as a side effect. But it's a real dilemma because for our oncologists, they don't really know what they're treating in the brain, and that is more and more of a problem if we want to get better at it. So they're relying on the postmortem to getting this from the owners eventually, but it would be better to have more biopsies. So it can be done, but at the moment it's still not widely used. Other than the brain, what we usually do is CT-assisted biopsies and FNA. So these are not real-time control. You're advancing the needle, you look where you are, and then eventually you do your biopsies in the trusting that your needle is going where you anticipated it going it. And this is an example. This is a lesion on the spine and ribs that we want to investigate. So what we'll do is we measure up the depths that we want to go. We measure up the angle from the vertical that we want to go in. We measure up the distance to a palpable landmark. Then we take our biopsy device, in this case a Jamshidi needle, and we will measure up the depths, and then we'll measure up the location from the landmark that we want to go in. We put the needle in, and then that's our depths that we measured. So, and we will CT this with going in only partially and checking that the trajectory is correct. So what you want to avoid is this needle position, because you don't really know where your needle is going. It's not in the line with the transverse plane of the CT. What you want is this. You want your needle perfectly aligned with your laser beams. And practically you do this like this. You switch the laser beams on and you really let the laser shine on your needle so that you know you're in. And you can see the needle isn't really far in yet, so you would CT it in this position to check that the trajectory is right. And then remeasure if you would go through the full length of it, where you would end up being. Now in this case, I have CT'd it with the needle in place, but normally you would only do these two maybe, and then do this procedure without checking at that point. And then it's crunch time. Yes?
When you measure the angle that you're supposed to go in with, you measure the distance and then the angle. How do you ascertain that you use the right angle?
Yeah, you can use what do you call this, angle measurement tool and hold it. I mean, yeah, the practical implications are pretty crude still, but that's why we check halfway in. So if you look at your needle here, and you put your measurement tool in CT on and you extend that to the length, then you know where you will end up with your lined up marker on the needle hub, because you have pre-measured that. So if I go all those 3 centimeters in that I wanted to, and along that trajectory, I will end up here, which is good or bad. Yeah? So for these mediastinal lesions, the ones that are dorsal to the heart, the only way to get a aspirate or any confirmation of diagnosis ante mortem is to do this transpulmonary CT aspirate. I don't do biopsy for that, but I do aspirates. When you do that, you create a pulmonary hemorrhage and you also create a pneumothorax. So the way you would do that is you place your needle here and you support it. This is a glove box, and put some gauze on it, keep it reasonably sterile, and you make sure you don't penetrate the pleura yet, so you don't create a pneumothorax. And you now reassess on your CT the depths of the needle, where it would go and what it would do. If you're happy, you then hyperventilate the patient, because after that they don't breathe anymore, and then you go in, suck, and come out immediately. You have the needle, the syringe already attached. And after the first one, if you do more, you don't hyperventilate anymore, because there's a leak now, and two leaks, two holes in the lungs. And after you've done with the whole procedure, you would wait 5 minutes, and then you CT it for pneumothorax to check how much there is that you created. In a case like this, I would maybe maximally do 3 aspirates, because you puncture the lungs on both sides, so you don't want to maximize that. In other cases, like the spine ones, I would do probably 5, 6, 7, just to make sure you get the diagnostic yield that you want. It's only an FNA, so don't expect miracles. But the CT allows you to get to places where you otherwise couldn't, like the medial pterygoid muscles, for instance. Or here, this abscess cavity. Okay, oops. That was quick. That was a bit too quick. All right, we talked about this one already. This is what we did yesterday, and we were so successful. But basically, this is a case of a suspected discospondylitis. And for that, you put the dog in lateral recumbency, possibly angle it a bit, because you need to go beyond the iliac wings, and you're trying to hit the end plates or the discs there, and to harvest that for bacterial culture to see whether this maybe is a discospondylitis, or whether, if you knew it was one, whether it's still active. Sometimes you treat them for months and months with antibiotic, and imaging-wise, there's still a regular end plate, and you don't really know is it still infectious or not. So it's an option that you have. So based on this, in general, radiography and fluoroscopy are not really good for imaging assisted tissue sampling. You only have one view, and you don't really know where you're going with your devices. So I don't think it's a good idea. Ultrasound, on the other hand, doesn't have superposition. So in areas where you can get ultrasound access, it's great, because you have real-time guidance. You see what you're doing when your needle is going in. So it's a preferred modality if possible. Also, with the CT technique that I showed you, because the last step is usually not guided, if you have organs that move away as the needle hits them, like a kidney, for instance, would, you know, you're not monitoring that, so it's not really good. So the CT is good where ultrasound doesn't work, and you don't have any other way of getting a diagnosis. So you get pretty much anywhere in the body, but it's not fully assisted. And you want to only use it for things that are not moving. So, and that's cryoablation. Do you do cryoablation? Used to be pretty popular. See, cryoablation is a technique where you freeze things to death. And do I have a picture of it? Oh, I thought I did. Oh, I had one. Basically, ice has a different density than water has. And so you can see the ice ball on a CT scan. So you can assess how much you froze. And therefore you can guide your cryotherapy with the CT. So you can do it in CT. So that's because there's a problem with cryotherapy is that you are guessing how big your ice ball is that you created. And with CT you don't have to guess that anymore because you can physically see it. It's more dense. Okay, and that's all I have for you. Thank you.